careful review of the previous operative report is mandatory in order to understand the surgical changes and adequately plan the intervention. Understanding the postsurgical anatomy is crucial for succeeding in balloon-assisted enteroscopy BAE endoscopic retrograde cholangiopancreatography ERCP. In general, BAE ERCP in patients with Whipple surgery or Billroth II anatomy is easier than in patients with Roux-en-Y anatomy. This figure shows the anatomical situation in 3 different Roux-en-Y settings. On the left, you see BAE ERCP in Roux-en-Y vertical banded gastroplasty. This is a complete gastric bypass. The figure in the middle depicts BAE ERCP in Roux-en-Y hepaticojejunostomy. On the right, you see BAE ERCP in Roux-en-Y after total gastrectomy. When performing BAE ERCP, it is better to utilize an enteroscope with a larger working channel, as it permits the passage of a larger variety of ERCP utensils. Moreover, for these complex procedures, it is wise to use insufflation of CO2 instead of air to minimize the patient's discomfort. The afferent limb can be missed during insertion of the scope, a finding that hints towards the advancement into the efferent limb in the fluoroscopic visualization of the endoscope in the mid-abdomen. Clues to the presence of an anastomosis are discontinuity and loss of Kirk-Rings folds, paradoxical peristalsis, and luminal dilation. Once the enteroenteric anastomosis is found, the enteroscope is directed into the right-sided opening, which often is filled with yellow-colored air bubbles. These bubbles are the result of bile saponification. If the scope is moving towards the liver shadow, has crossed over the spine from left to right, and has assumed a spiral shape, the afferent limb has been intubated. Successful deep intubation of the afferent limb is defined as localization of the oral end of the anastomosis. After identifying the pouch, the scope is retrieved to locate the hepaticojejunostomy or papilla, usually 10 to 15 centimeters distally. Generally, the opening of the hepaticojejunostomy is very small. When there is no complete bile duct obstruction, bile or a mucoid substance can be seen flowing out of this small orifice. In such circumstances, the opening may be as thin as a 0.035-inch guide wire. But occasionally the hepaticojejunostomy opening is very large, permitting the introduction of the tip of the double balloon enteroscopy DBE into the common bile duct, therefore allowing the performance of a direct cholangioscopy. We have proposed a useful endoscopic radiologic classification which classifies the hepaticojejunostomy into small and large orifice and short and long stenosis. In our experience, cannulation of the hepaticojejunostomy is not a major challenge. Cannulation of an intact papilla is more difficult or impossible. Existing stents facilitate cannulation of the bile duct. BAE ERCP allows for a myriad of diagnostic and therapeutic interventions in the biliary tract. Here we see an example of balloon dilation in a patient with stenosed hepaticojejunostomy, cholestasis, and recurrent cholangitis. This other patient had a small but major stricture that was treated with double stenting. In this 65-year-old patient, multiple stones were extracted with a basket after the hepaticojejunostomy was dilated with a balloon. This patient with a Billroth anastomosis and cholangitis underwent a sphincterotomy-followed stent insertion. BAE ERCP is a useful addition to our endoscopic armamentarium.